clinical outcomes at 2 years and 5 years than decompression surgery alone. So they could not find fusion is adding something better to the outcomes. Another work from 2017 comparing 5 studies, no conclusion regarding which treatment is better. However, side effects of surgical group is between 10 to 24%, and they could not find a superiority of any technique to the other one. Instead, there is some higher complication rate in the surgical group. In conclusion, the relative efficacy of various surgical options for treatment of spine stenosis are still uncertain. Decompression plus fusion is not more effective than decompression alone. This is the conclusion of 2015 work. Interspinous process spacer devices has resulted in higher reoperation rates than bony decompression. So they don't recommend using interspinous process devices. What can we tell at the end? Decompression is the basis of surgical treatment for lumbar spine stenosis. Indications of surgery are mostly just a claudication and to increase the quality of life. Unilateral approach bilateral decompression is currently most popular surgery, but its value is not much validated yet. MIS techniques for spine stenosis have significant advantages, less complication rates, and very quick return to work or daily life. Fusion is an option, especially when listhesis or instability are present, but indications are still controversial. Decision-making for complex spine stenosis is quite difficult. Decompression without fusion in degenerative listhesis is possible. We must always have additional back pain to indicate a fusion, overt instability, preserved disc height. Probably female patients are more prone to develop instability. Better to perform short fusions. In elderly populations, the fusion surgery has up to 25% complication rates. So our decision should be affected more with clinical symptoms than radiology. There is no good correlation between radiology and symptoms. We must stress that point. It's very important. This is my algorithm for neurogenic claudication patients. The first question is asking whether they have back pain or not. If there is no back pain, consider first the decompression alone surgeries. If there is some back pain, and if there is no significant instability, then facet injections, sacroiliac joint injection, brace and exercises may be a good option. If they don't benefit from such conservative measures, then you can think about decompression and fusion. If there is significant radiologic instability, yes, this is inevitable to make a decompression and fusion. I end my talk here, and then we postponed our meeting, Istanbul Spine Masters, to October 1-3. I guess we can achieve it. Everything is settled. There is also a full endoscopic course during that meeting, and our Milan meeting has been postponed to March 2021. Thank you for listening.
Thank you very much, Professor Zilaeli. This is an important area, lumbar canal stenosis, and you gave a very thorough treatment subject. Can I ask Professor Miguel Aras, do you have any comments on Professor Zilaeli's talk, any questions or Any observations from your practice, sir?
Thank you. Thank you. Good morning, everybody. First of all, congratulations, Naren, again for this wonderful initiative. I'd like also to congratulate Professor Sileli for the wonderful, very well done, and I appreciate a couple of things regarding the presentation of Professor Sileli. First of all, the issue of the current refinement of the surgical technique by means and basically this microsurgical or endoscopic approach. I'm also in favor of microsurgery for this sort of approaches. And I also very much appreciate your comment regarding the need for fusion. My humble understanding regarding spinal lumbar stenosis is that in many instances after surgery, there is no at all the postoperative instability. So there is no need for fusion. I think that when we are facing a patient with spinal stenosis, you know, the facet joints and everything is so big that even drilling a little bit, some small proportion of the global volume of the joints, and also due to the stage of advanced degenerative spine that is almost spontaneously fused or at least with less mobility. In summary, I think there is no need for fusion. This is my comment, and I'm glad Dr. Sileli is in agreement with me. I have one question for you. What is your point of view and your surgical attitude when you have a patient with degenerative spondylolisthesis, no lysis, lateral stenosis, provoking basically radicular symptoms, but the patient has grade 1 spondylolisthesis? Do you fuse or not? What is your opinion?
Yeah. We must have additional information to decide that. One is whether the patient has back pain. Does he have back pain?
Okay. So
Back pain?
imagine the patient doesn't have back pain, first possibility.
Yes. If there is no back pain, I would be more on the side of decompression alone surgery.
Okay.
But if there is significant instability sign on the films, like if on the functional films it's moving, if there is significant modic changes at the level, so I will discuss that with the patient. I would tell the patient that after the decompression surgery, you may have more back pains after all, or it may recur again. The same level may get rest stenotic.
Okay.
If you accept that, I will do just decompression, I would say.
Okay. I have a second question, taking advantage of your expertise, Professor Sileli. Imagine the patient have back pain. Imagine there is some sort of movement in the functional images, functional X-ray films. Do you consider for those cases, I think this question could be almost in everybody's mind, is there any role for these new devices for interspinous fixation? That is something simpler than the pedicle screws, using with the aid of some fusion with autologous bone and bone promoters and things like that. Is there any role for interspinous fixation devices? This is the question.
Yes. In fact, there is no class 1 evidence that interspinous devices are helpful in lumbar spinal stenosis. There is no class 1 paper. But there may be limited indications for that. Those are moderately stenotic patients who are having neurogenic claudication by very in lordotic positions, I mean during walking. Those patients can benefit from interspinous devices for a while. But they must be moderately stenotic, not severely stenotic. And they can have back pain or not. It doesn't matter.
Okay.
But unfortunately, no good evidence in the literature.
Okay. Thank you very much. Thank you very much. Congratulations again for your wonderful lecture. And thank you for sharing with us your experience. Thank you.
Thank you.
Thank you very much, Professor Miguel. There's a couple of questions, Professor Zileli, on the chat area. I will just take one question. If you would please kind enough to take time to answer them on the chat box. The other questions I will be grateful.
Okay, I will.
One question is from Dr. Najar. He's saying, Professor Zileli, thank you for your presentation. What's the cause of high percentage, 25% as I read, in failure of fusion in stenosis treatment?
What's the cause? No, this is if you apply instrumented fusion in the older cases, in the elderly patients. It is in the elderly patients. Some of the complications are like because of bleeding, they can have intraoperative hypertension, hypotension, bleeding-related problems. They can have, since they have osteoporosis, implant failure rate is quite higher. And the infection rate may reach up to 5% in some series. Because of that, the total complication rate in the long term, if you follow them good enough, may reach up to 25 in elderly patients if you perform a fusion surgery.
Thank you. Thank you very much, Professor Zileli. It was a fantastic lecture. I really enjoy and learn a lot from your talks over the years.
Thank you.
Thank you very much. And once again, there are a few more questions on the chat box.
Yeah, I will answer them.
Great, thanks. Mr. Andreas Dimitriadis, can I please invite you to share your presentation, please? Thanks.
Certainly.
Thank you.
Good morning, everyone, and a big thank you to Naren for the kind invitation, and very well done on your continued and pioneering work on connecting us.
Thank you, Andreas. Just to introduce Mr. Andreas Dimitriadis, we are good friends for a long time, and he's in Edinburgh, neurosurgeon and spinal surgeon there, and he's also the president-elect of the INRC. Congratulations. I expect great things from you for the INRC, and congratulations to INRC. And I'm really looking forward to your lecture on Koda-Equina syndrome. It causes a lot of angst, and thank you very much again.
Thank you again, Naren. Very kind. It's an honor to join everyone today. I have to also thank Professor Kamal Prasad, who made all the preparations to host everyone in person, but had to adjust to online given the pandemic of coronavirus. My assigned topic was Koda-Equina syndrome, and I was asked to address some of the controversies. And there's plenty of them, starting from the diagnosis, which in itself causes a lot of litigation issues, especially in the setting where I work in the UK. But I'll discuss some of our work that we have done in our department with regards to the incidence of the condition, the correlation to its between its clinical and radiological findings, and some of the long-term outcomes. I'll share with you at the end our pathway and some of the forthcoming results. diagnosis of Koda-Equina syndrome is a clinical radiological diagnosis, and it consists of having at least one or more of the following group of symptoms: bladder and or bowel dysfunction, saddle anesthesia, and sexual dysfunction, with or without possible neurological deficit in the lower limbs. This, to complete the diagnosis, has to have radiological correlation, which would account for dysfunction of the sacral and lumbar nerve roots within the vertebral canal. The diagnosis in itself has a lot of problems, if you like. There are high litigation rates, especially in the UK, which leads to defensive medicine and maybe an overcautious referral pattern. The incidence in itself is very unclear. And we were told in the past, or we have read in the past, that that very small number of 0.0004% of all patients with back pain will have this. Other claims is that only 1 to 2% of disc herniations will come to this syndrome needing surgery. But given those factors, we still have high referral rates because of probably a low threshold. Again, I stress specifically in the UK. There is also no reliable clinical filter, and there's plenty of people who show up with good going symptoms, but an MRI is negative. So the only answer eventually is the MRI. This becomes a problem in our setting because we have a centralized out-of-hours MRI service, because the district hospitals without neurosurgical presence will refer to the tertiary neurosurgical center for the MRI, which means a high volume of out-of-hours scans can be encountered. Of course, there's devastating symptoms causing a social and socioeconomic impact, and some of the long-term outcomes had not been clearly proven in the past or examined. I'm showing here a picture which shows three major medical malpractice insurance companies or medical indemnity organizations. On your left is the Medical Defense Union. On the right, on the top, is the Medical Protection Society. At the bottom is the Medical Defense Union, Medical and Dental Defense Union of Scotland, and they all have had a strong involvement in defending doctors from Koda-Equina syndrome claims. The litigation picture is relevant because it creates a burden, and over a five-year period, the NHS Litigation Authority, which defends claims against the NHS for medical negligence, has responded to nearly, it's at least 80 claims. I think now the number has exceeded 100 per 5-year period. It doesn't sound much, but actually, if you look at the fact that of those settled, the average compensation is in excess of £200,000, and the highest settlement to date at over 2 million. And at the bottom, I'm showing you, if you go to Google and search for Koda-Equina syndrome, most of the hits I get are actually legal rather than medical. This is another such medical legal advertisement, if you like, showing at the bottom a trophy with an average compensation settlement of £800,000 plus and an average of £360,000. And if you look on the bottom left, even during the COVID pandemic, in the legal profession, business is as usual. And of course, patients who suffer will consider litigation. The costs are high. 12% of the cases settled receive compensation payments of over $500,000. And the MDU in itself identified that over the same time period, the payments had reached $4.5 million to include the solicitors and the claimants' fees. Interestingly, since 2017, the Medical Defense Union, which is the biggest defense organization, has stopped providing cover for neurosurgeons and spine surgeons because there's more and more cases coming through and the costs are increasing. So let's move away from this and try and find out why there's so much litigation. It's because there's so many controversies. And the first one is we don't even know what the true incidence of Kodak-Koena syndrome is. This is one of the articles generated by our department, whereby we found that this was not an easy answer. We found difficulties in comparing between studies because there were heterogeneous definitions of the syndrome. There was lack of separation of the advanced cases with retention as opposed to the ones which are coming through and are labeled as either potential or threatened or evolving syndrome. Most of these studies have small samples. They consist of single center studies. Most of them seem to be coming from the UK because of the high profile this condition holds. And of course, most of them are retrospective and if you do a search, you'll find also a lot of abstracts as well as full texts. So I'm showing you here a forest plot on the left, which looked at the reported incidents by different studies in secondary and tertiary care. And the systematic review has summarized this as a 19% proportion, if you like, or incidence. And on the right, we looked at the patients who had back pain presenting to secondary care, and the incidence of Kodak-Koena syndrome within that group is less than 0.03%, so very small. But I guess the take-home message from the systematic review is that Kodak-Koena syndrome occurs infrequently in asymptomatic community populations, and in those presenting with symptoms, it's up to 19% from the systematic review. The next question, which is the reason why a lot of people do study this condition a lot, is how much correlation is there between the clinical and the radiological findings. And then another study within our department, out of 276 consecutive Kodak-Koena syndrome referrals, not confirmed referrals, not confirmed cases, but referrals for query Kodak-Koena syndrome. Out of those, only 28% were scan positive. So almost 70% were scan negative. And no more than 3% of those with a negative scan eventually found an alternative cause that had created these symptoms. And therefore, we also found that there was no single clinical feature which differentiated between these groups. So again, that means we have to do the MRI if we have any kind of suspicion. So the question has always been in my mind, since we're getting such a high volume of referral, and that comes with a high cost of negative scans, what happens to these negative scan patients? And the answer is, it remains very unclear. We have a prospective study that is not published yet, so I cannot share the results from that, but I'll share with you. Ingrid is one of our neurology trainees who's been doing a PhD on the topic, but this short report was quite illuminating in that it showed evidence of functional neurological disorder in a prospective small series that has led to more work. In this study, they had only a very small proportion of cases, but you can see that there was a 90% Hoover's sign and 45% dissociation in those with negative, and these were much smaller, or almost zero, in the positive true Kodak-Koena syndrome cases. And that is relevant in the sense that it points to a psychogenic and non-organic disorder or functional disorder. These are cases which are not imaginative. The symptoms to those patients are real, and they come because of a problem with the functioning of the normal bodily processes. The diagnosis is based on positive clinical features, and it includes diagnoses such as fibromyalgia, inflammatory bowel syndrome, and of course, functional neurology. I urge you to search and look for the Hoover sign, which is demonstrated in the pictures by Dr. Stone, one of the experts, which is a sign of a functional disorder, whereby if you ask someone to flex specifically a particular muscle and they can't do it, in a functional disorder, this person will actually activate that muscle if they're then asked to do something else and they're being distracted. Moving away from that, one of the other controversies are the long-term outcomes after Kodak-Wana syndrome, and we struggled to find good data, and that was the incentive to do the study quoted there. That included a lot of questionnaires to address all the relevant categories of symptoms. But I'd like to share this slide, which shows which symptom patients valued treatment for after discharge. And it clearly shows that it was that they have persisting back pain and leg pain, much more so than numbness, weakness, and they also have less requests for bladder, bowel, sexual symptoms. Now, that's not necessarily they don't have them, but this is the symptoms they ask for help. And if we also look at their reported post-discharge healthcare service use, the majority comes from physiotherapy and urology, very little for pain management and other symptoms. To summarize our results, and I'm happy to share the PDFs of the articles, with a mean follow-up of 43 months, so between 3 and 4 years, there was high prevalence of long-term disability. 76% continue to have bladder dysfunction, but bowel dysfunction is much less at 13%. However, sexual and physical dysfunction are rated very highly still. The next point is that those that present with Kodak-Wana syndrome with retention, in other words, a complete Kodak-Wana syndrome, had significantly worse long-term outcomes in bladder, bowel, and sexual function to those with Kodak-Wana syndrome incomplete, which makes sense. And that means that these are the patients who would benefit most from expeditious treatment. And I mean, the timing of treatment is in itself another controversy, which I am not addressing in this talk, because it is generally accepted that the sooner the better, ideally within 24 hours, or failing that, within 48 hours. But there's also other controversies into that. Perhaps the damage is done at the point of acute compression, and it may well be that some people will never get full recovery after established symptoms. The other point was that pain was chosen as the symptom patients would value most treatment for, with 57% doing that, and only 7% reported post-operative pain management referral. So even though pain is the main issue, there is some underutilization of specialist services in the outpatient post-operative setting. At this point, I'd like to show you our pathway for suspected Kodak-Wana syndrome. We get referrals from both secondary centers and specialties such as orthopedics or medicine or urology, but also from primary care. We will bring them in, perform the history taking, the examination, and those who of whom we are suspicious, we will perform the MRI. So that brings us to this stage here. We always try to do a post-void residuals ultrasound scan. Those who have a positive scan will proceed on the left part of the flow chart and have surgery, and those on the right will be labeled scan negative cases without structural explanation, and those will be considered for a full neuraxis scan plus neurology review. Certainly during the study time with our neurology colleague, there was consideration of lumbar puncture and even an MRI brain as an outpatient, but obviously not in any urgent manner. Very few cases would proceed to neurophysiology as the neurologists deemed appropriate. The post-op environment, I think, is worth noting in that we should definitely engage with physiotherapy for the ongoing rehabilitation. We should definitely use pain clinic, and I know it's an overloaded system, but these patients seem to value it from what they're reporting. And of course, if we have persisting sphincter issues, urology or urogynecology, in my opinion, have provided excellent further support. Future directions with the heavy involvement and guidance of our trainees, is shown there, Julie, Ingrid, and Eamon. There is a prospective Kodak-Wana syndrome study, which will soon share results. And there is also another prospective case control study for those with scan negative, which again, hopefully will be sharing results. But to move to some basic conclusions, number one, almost 70% of patients in our setting with suspected Kodak-Wana syndrome have normal or non-explanatory scans. That's a cause for concern from the cost efficiency point of view. Only 3% of the scan negative group had an explanation for their true symptoms. Again, that's a cause for concern as to what is the appropriate care for these people. We do have, for those who have true Kodak-Wana syndrome, long-term disability with bladder dysfunction, bowel dysfunction, as well as sexual and physical dysfunction. And those with a scan negative Kodak-Wana syndrome do seem to have high rates of functional disorders and psychiatric comorbidity, and that might in itself be identifying a specific subgroup for further investigation. I would like at this point to acknowledge all the patients and staff at the Western General Hospital in Edinburgh, and all our trainees and colleagues, and finish off with sharing a picture from one of the many scattered castles in Scotland, and finally invite you to the 20th Congress of the ENS in 2020 in Belgrade, which hopefully will run in October. Thank you for your time and attention.
Thank you very much, Andreas. Fantastic talk. It's a condition that pretty much every neurosurgeon, every adult neurosurgeon sees every week or needs to know about, and causes a lot of angst for both the patient and for the doctors. While questions come through on the chat box, I just want to ask a couple of points. You have to appreciate that while I'm listening to the talk, I also have to move around and make sure everything is okay. So in case I miss it, I apologize. I think I saw a paper from you and your team about asking history about sexual dysfunction in clinical assessment. Could you just tell me what did you guys found? If you have already told, I'm sorry.
Yeah, that's right. I didn't include that, so thank you for giving me the option. That is a paper that was titled "Are We Neglecting Sexual Function Assessment in Suspected Kodak-Wana Syndrome?" And it was born out of a concern of how well are we documenting these patients that are coming through, because if we're, and the reason behind that was we're planning to do a follow-up study of the long-term sequelae, and therefore we were wondering, well, how well are we documented up front before we even check it long term. So basically, out of 120 patients, which we surveyed in this study, 25, so that was a particular group, 120 patients referred, and 25 had radiological Kodak compression, so slightly different study setting. Lower limb neurology, urinary function, and subtle sensation were almost universally documented by the person who was clocking the patient in. However, the symptoms of sexual function was poorly documented with 3%. So after this audit, we did an intervention, if you like, where we educated everybody, gave an in-house lecture and talk, and also induction of the rotating residents. And we repeated the study. So again, the documentation of bowel function, bladder function, and lower limb neurology function were universally documented, and the sexual function improved from 3% to only 11%. So the answer is, unfortunately, that certain clinical features of Kodak-Kwana syndrome are not well documented, and increasing awareness can improve documentation, but sexual function remains, perhaps for social reasons, poorly documented.
Thank you, Amit. Just one follow-up question. I think you have got many questions coming. Is that what's your policy regarding PR exam in your department as a pre-op assessment?
Thank you. Good question, and a matter of debate in-house and elsewhere. Personally, I think it's unnecessary. That is not the main clinical sign that will determine whether the patient proceeds to an MRI or not. The history is very strong. If someone has already had incontinence episodes and describes back pain, leg pain, and radicular symptoms, they're going to have an MRI anyway. So subjecting them to a socially invasive part of the investigation with very poor specificity and sensitivity, I would personally not do it. But we can still do peri-anal or saddle sensation testing, but not digital rectum examination, in my view.
There are many questions, but I just want to, if that's okay, bring Dr. Prasad. Dr. Prasad, in terms of Kodak-Kwana presentation timing, how is it? Is it quite delayed in India, or do they come present early enough, or your hospital setting might be different from normal public hospital? What's your observation?
It's very different, Naren. Like we, first of all, the difference is that like we are not seeing that much of litigations for whatever reasons, and it's good for us. And we keep seeing Kodak-Kwana more commonly for tumors, slow-growing tumors, this ependymomas, and sometimes neurofibromas. As we are talking, I am getting a query from a northeastern state of India, which is around 2,000 kilometers from here, who wants to shift his father. Is I think around 68 years or so, with what appears like Kodak-Kwana because of a tumor. He has sent me a report which says just it's a 6 centimeter long, 3 into 2.5 centimeters, big lesion around the Kodak-Kwana with bowel and bladder involvement. And unfortunately, there's no way they can reach here, and it's already looks like it's more than a week. And the only way he suggested me, like the local therapist has suggested radiation, and I just told him to go ahead. These are very uncertain, very difficult times. This is the reality here. There's no way he can reach here because of the lockdown. He stays 2,000 kilometers away, and he's already having symptoms for more than a week. And I'm not sure whether I was right, but rather than like not doing anything is still worse. So I am suggesting to follow the radiotherapist advice to give 5 days of radiation, what he has suggested. very difficult here.
Thank you. Andreas, I'm just going to use my privilege and ask you a few more questions before I let it to the audience. It's a hot topic. One is that, is it worth operating after midnight on Coda Equina? And the number two is, should consultants be there at the operations? One is in terms of outcome, one is in terms of missed levels, wrong levels, and the poor registrars then being hammered.
Good question, and again, no single best answer. The question of after midnight has long been debated. I think I can't give you a definitive answer. If it were me and I was having Coda Equina syndrome, yes, I would probably be keen that I were operated as quickly as possible. So if one presents 40 hours from symptoms and it's midnight, waiting till the morning might ensure that the recovery is further hindered. In some occasions, if one is referred late and by the time they come to your hospital or our hospital and go to theater and start the case, sometimes it makes only a difference of 2 hours. So accepting a referral at midnight might actually mean that you start at 5 or 6 instead of 8. So that difference, I think, is minimal. But if you're able to start at midnight for someone who really needs it because of time issues, I would definitely consider it. I would never say never and never say always. I would consider it on each case depending on the severity. So especially with more data coming through that Coda Equina syndrome incomplete, they are more time critical. If someone has complete symptoms, they seem to be less likely to recover than the incomplete. The other question of who and when, of who rather than the when, I think things are changing, and it's certainly expected that the consultants should do more and more of the cases. But of course, one has to judge the competence and level of trainee who is available to do any surgery, not just this. So for example, if you have a very competent trainee who's about to qualify, I don't think going in would be necessary, and it might even undermine the trainee. If on the other hand, you know a trainee is junior, is not able to deal with the potential difficulties of a case, or if a patient in itself makes the case difficult, like body habitus, likelihood of increased venous bleeding, etc., I would err on the side of caution.
Thanks. I'm going to just put one more question, and there are more questions for you on the chat box. If you can please answer, I will be grateful. One straightforward question, but never anything is straightforward, but important question. Dr. Garav Singh is asking, for treatment of Coda Equina, microdiscectomy alone or wide decompression plus microdiscectomy, or just wide decompression?
Yeah, no, I think it's a good question, because there's been a tradition, an old tradition, that whoever comes with Coda Equina syndrome should have a very wide laminectomy, etc. But I'm not convinced this is the right answer in every situation. If you do a microdiscectomy and you feel that the dura is very well decompressed, there is no need to do any further anatomical disruption. So, I mean, we need to make sure we have a good decompression. That's all that matters. Whether we do that with a discectomy or discectomy plus hemilaminectomy or full laminectomy, it's down to the operating surgeon at that time. But I wouldn't say you must always do a full laminectomy. That is something that was pushed forward for years, and I think that's not always necessary.
Thank you. Thank you very much, Mr. Dimitriadis. As I said, you have got so many questions. I really will appreciate. For the reasons of time, we will move to Professor Salman Sharif. Professor,
thank you again from my end. Very much.
Thank you very much, Andreas. Professor Sharif, can I please ask you to share, welcome to the course, and may I please ask you to share your presentation with the audience? Thanks. Great, thank you very much. So it really gives me a great pleasure and to introduce Professor Sharif, who's from Karachi. He's very active, not only in the surgery, but in terms of education, not only in Pakistan, but around the world. And it's an honor and privilege to have Professor Sharif on a busy day. We have managed to pull him into this meeting. Professor Sharif, the floor is yours now.
Thank you, Naren. First of all, I'd really like to thank you for organizing this. Wonderful to see all these galaxy of really top people joined here and trying to teach on a Saturday, which is great. Sorry, I was just doing some urgent surgeries, which were a couple of tumors, and that's why I ended up being in theater. But generally, Saturday is my operating day, and I work on Saturdays anyway. So this is an interesting topic, and that's we have gone through the rigmarole of this topic in detail by making some consensus and guidelines from WFNS Spine Committee. So just going to go on to that. Let's see. There we go. Pakistan, as you all know, this is K2 base camp during the early morning time. This amazing Karakoram and Himalayas range that we have in north of Pakistan, and some of the mountains are the highest in the world. This is the whole range seen from Ahmedabad, which is really on the plains of Khyber Pakhtunkhwa, one of our famous area. Basically, what we have been doing up till now is using traditional plain radiographs, and we were evaluating the bony components, and they were slowly replaced over time. And now that is the reason being when the patient comes in with a trauma or cervical injury, we use a multi-detector CT, and they're done in a special way, and we all know that. And that is now guidelines all over the world. What about MRI? MRI ideally should be obtained if feasible within 48 hours. If you really want to look at the prognosis, it detects lesion in about 6% of cases in which the CT may be normal, particularly the ligamentous lesions, and it may be a valuable tool to classify severity and predict outcome based on the presence of hemorrhage, extent of edema, and severity of the initial compression on the cord. Intraspinal hemorrhage more than 1 centimeter, as well as longitudinal T2 signal changes more than 3 centimeter, clearly have a very poor prognosis. A normal initial MRI scan is usually associated with complete injury, and we know this, and this is from multiple studies. MRI plays a critical role in evaluating and detecting spinal trauma, subtle bone marrow, soft tissue, and spinal cord abnormalities, which may not be apparent on other modalities, may be detected, and we can detect early and have prompt and accurate diagnosis and expedite management and avoid unnecessary procedures. In case of spinal cord trauma, contusions, and hemorrhage, MRI may be the best prognostic indicator. The parenchymal spinal cord injury on MRI not only correlates well with the degree of neurological deficit, but also bears significant implications in regards to prognosis and potential for neurological recovery. Why would radiological prognostics criteria required? How does it help? The ability to predict functional outcome, which can influence rehabilitation strategies. You have a better understanding of degree of neurological impairment related to spinal cord injury with concomitant head injury or anything else that we can't examine, or assessment of neurological injury in children. Assessment of spinal cord injury integrity below the level of injury, and measurements of cellular changes in response to neural repair or biological therapies directed towards the injured spinal cord, which is the future actually. The impact of facet dislocation on clinical outcome after cervical spinal cord injury was looked up by this group, which has looked at many other things. And in 2013, they published 421 patients. Of those 135, 32% had fracture dislocation, and 67% did not have them. Compared with patients without fracture dislocation, cervical spinal cord injury patients with fracture dislocation tend to present with a more severe degree of initial injury and display less potential for motor recovery at 1-year follow-up. And another study from India showed bilateral facet dislocation are more mostly low velocity injuries, and have poor neurological outcome. MRI factors and advanced imaging that predicts outcome. So what else can we do? So this is a study that basically looked at the prognostic role of MRI in spinal trauma, comparing with clinical profile and neurological outcome, and according to Asia impairment scale. And what they did was they looked at the sizable focus of the hemorrhage. It was more than 1 centimeter, less than 3 centimeter, more than 3 centimeter, along with cord edema, and otherwise no finding of myelopathic changes. So they looked at all these and looked at what factors were contributing to the outcome. So patients with presence of sizable focus of hemorrhage that is more than 1 centimeter had a larger cord edema and more severe grade of Asia impairment scale with poor recovery at 1-year follow-up. Then there was this scale, Brain and Spinal Injury Center score, which is called BASIC score. This is a simple score that was published by Jason Talbot. They looked at 131 patients who had principal diagnosis of spinal cord injury. And in this score, as you can see, BASIC 0 meant there was no appreciable intramedullary cord signal abnormalities, so nothing at all. On the other hand, BASIC 1 had intramedullary T2 hyperintensity, which was confined to central gray matter, just like here. So only central gray matter was confined, that kind of injury. BASIC 2 was going beyond the gray matter into the white matter, but not involving whole of the cord, not the entire transverse diameter. BASIC 3, when all the entire transverse diameter was involved, and BASIC 4, when you had all that, along with that, you had macrohemorrhages, which are seen here, as you can see. So they divided these into these different scores and then looked at different levels of cervical cord. And they found this very interesting results that patients who had BASIC 0, basically having no injury, obviously some of them were Asia D and they all turned into Asia E. So everybody in that group turned into Asia E. So they all became normal. Patients who were in C, D, and E, majority of them, BASIC 1, converted into D and E, they improved. Whereas BASIC 2, in which there was involving a white matter as well, there were A, B, and C, and they converted to C and D. In the patients with BASIC 3, some of them did improve, but majority of them remained in Asia A. And with hemorrhagic contusions, all of them did not improve. So if you knew beforehand that these patients are not going to improve, so just by doing a particular surgery, etc., then you need to be thinking about how we're going to take care of those patients. It was an excellent prognostic potential across all spinal cord injuries. It helped distinguish between patients who present with Asia A that would improve or not, and it's a rapid to apply and inter-rater reliability is excellent. Then look at multivariate analysis of MRI biomarkers for predicting neurological impairment in cervical cord injury. There's a retrospective cohort study of 95 patients with acute injury, and they did a preoperative MRI within 24 hours. And they looked at various features, brain and spinal injury score, BASIC score, sagittal grade, length of injury, maximum canal compromise, and maximum spinal cord compression. And when they looked at the length, the maximum spinal cord compression at different levels, and the maximum cord compression itself, and then had the BASIC score and the sagittal grade according to the levels involved, they could say that the outcome for this particular patient is going to be A, B, and C, and this patient may not have that. So they were able to predict according to that. Now then we looked at role of DTI. DTI is more sensitive biomarkers for spinal cord damage than standard T2 weighted image for both kind of spinal cord injuries. DTI indices include aberrant diffusion coefficient, fraction anisotropy, and mean diffusion, radiation diffusibility, and axial diffusivity. And the conclusion from that study was that the intrinsic measures were basically this. I just put it up there. We have 3 webinars today, and I'm giving another talk in 2 hours, and then I have another one this evening as well. So slowly and gradually, we are going to that stage. So what do we know so far regarding DTI? It's mostly studied on animal subjects up till now. There were few clinical studies conducted so far, total of 39 studies when I last looked at, and only a couple of studies in the last 1 year with at least 1 year follow-up. And we looked at correlation of MR diffusion tensor imaging with Asia motor scale. And when we looked at that, 25 patients, both blunt spinal cord injury and 11 volunteers, and DTI parameters reflected the severity of spinal cord injury and correlates well with Asia motor scales in patients with non-hemorrhagic cord contusions. And this is how DTIs look at when we go through each and every level. Again, DTI, 30 patients with spinal cord injury, follow up for a year. They looked at axial diffusivity, basically mostly strongly correlated with the motor and spinal cord independence parameters. And they found that axial diffusivity was more specific parameters than anything else. So axial diffusion was more important. DTI and chronic spinal cord injury, again, they looked at those values and they felt that these values seen in spinal cord injury subjects are likely due to demyelination and axonal degeneration of spinal tracts, which are related to clinical and electrophysiological measures. Quantitative evaluation of extent of spinal cord damage and eventuality to monitor the effects of future regeneration inducing treatments may be the way to go with DTI in future. We have limitations. There are no standard functional outcome scales out there to look at the prognostic value. Spinal hardware around the injury makes it really difficult, gets a lot of artifact with MRI. The acute clinical condition of patient may not allow such investigations to be performed. DTI, again, in 20 symptomatic patients, changes in DTI parameters, most marked at injury sites and reflect the severity of injury. It indices, provides quantification of microstructural neural damage, which may help guide prognostication in patients with acute or spinal cord injury. Now coming to functional MRI. This non-invasive modality relies on changes in blood flow and oxygen levels that occur in metabolically active neural tissue that is responsible for a tested neurological function. The signal chain is related to both the blood oxygen level dependence, which we call bold contrast, and signal enhancement from extracellular water protons caused by an increase in water contents in the area. Spinal functional MRI was able to map out the areas of function related to motor and sensory function. So what is the potential? It was able to form a paradigm in a cohort in 12 patients with traumatic spinal cord injury, and neural activity was present in all patients irrespective of degree of injury. We could even see beyond if the injury was complete, we could still see there was what kind of function is going through. So in summary of sequence of all these, T2 weighted, we can clearly visualize compression, edema, hemorrhage, and rationale is management and prognosis can be formed from there. Same goes with axial T2. Obviously, this herniation, cord compression, same management and prognosis. Sagittal and axial T1, ligaments, cyst, mechanism of injury can be known. Stir and graphs we use for looking at ligaments, and then mechanism of injury can be known. Functional MRI with bold contrast, it is still investigational. DTI, white matter tracts, investigational, and can be a helpful tool in prognosis. Comparison of various MRI sequence by our friends in 2015 showed that DTI matrix functional anisotropy had the strongest value of utility with moderate degree of evidence for its use as biomarker, showing correlation with disability in severe clinical pathologies. So results in their study showed that images, among these images tools, DTI was the most mature, but further work is needed to standardize and validate its use before it can be adapted for clinical reality. Clinical future applications, advanced spinal imaging will likely play a critical role in helping to determine the efficacy of these treatments. Potential applications could be serial DTIs, perfusion MRI, PET scan with FDGP. Limitations we already talked about. So predictive radiology, that presence of facet dislocation on CT is suggestive of poor neurological outcome. Class 2 evidence. MR T2 weighted is an acceptable method to rapidly screen patients with cervical injury, again class 2. And predictive finding on T2 sequence, including sagittal grade, length of injury, maximum canal compromise, and maximum spinal cord compression. Axial grading, basic score provides the best and easy means to predict outcome class 3 evidence. And at the moment with DTI, that it may be a possibility to predict outcome in future. With all these various webinars going on, we have an IFNE, WFNS endoscopy webinar this evening at 5 from Karachi. We have a spine committee webinar at 2 o'clock Istanbul time. And then we have a webinar tomorrow by PSN with Hassan Sayed and Greg Frost. And our famous Atul Gol is back with us again with a webinar on Monday. So with really gratitude to everybody listening and greetings from Pakistan, I'm open to questions. Thank you.
Thank you very much, Professor Sharif. This is a very important topic because it's not unusual once the patient has a spinal cord injury, the neurosurgeon's interest go without putting a lot of thought into the patient about the prognosis and how, and that has lots of implications if we start to actually look at something carefully, and these prognostic markers are important. Can I please ask Professor Gol, I'll just a second. Just while I try to get Professor Gol, I'll just put the questions from, there's a question from Dr. Badjiwal. Any correlations or guidance in MRI T2 changes and the role efficacy of early steroid administration in spinal cord injury?
No, not yet. There have been some studies, but unfortunately, we don't have any scientifically reliable studies. So studies have been come out, our majority are case series. So there are there's some group who have tried this, but it hasn't showed any difference in between the two. Is there any progression in improvement or not? No.
Thank you. And in reality, has spinal slightly different from the specificity of the talk? How far away are we from any stem cells, etc., for spinal cord injuries? Is that still far away?
I think, as we all know, that stem cell has worked very well with animals, but unfortunately in humans, the results have not been uniform at all. And patients who have improved with stem cell, majority would have improved anyway with rehab and physiotherapy. So I think many people, although are giving stem cell, but are not quite sure the way forward. I think what's happening is this groups from Switzerland and from Duke are coming up with having this brain-machine interface or dorsal column stimulation along with functional electrical stimulation. And they have shown in their patients that they were able to improve. For example, up to now, there have been 7 patients in different groups who are able to walk when we switch on with the help of a watch, the functional electrical stimulation. Some of them are able to even without any stimulation, walk with the help of maybe a stick or a little bit of a support. Some of them are able to do without it. So I think there are changes, and these are chronic patients. These are not acute patients that have improved. I think future is there for us to take, but I think stem cell has not turned out to be the real goal that we thought it's going to be. So I think, but there are other modalities that have really come up. I think functional electrical stimulation is very simple. Even in places like Pakistan and India, we should be able to use that. And there are rehab with various ways. All the other studies have shown some promise, but have really not shown a clear-cut difference that you latch onto it and move forward.
Thank you. Professor Zilaeli, do you have any comments regarding prognostication? Yes. Your comments on Professor Sharif's talk. Thank you.
Yes. Salman, welcome. How are you?
Thank you. I'm good. How are you keeping, Professor?
Good. Actually, it was a very updated talk. Recent studies you summarized very well. For the question of stem cells, whether they will have a role in the spinal cord injury regeneration, I guess we are almost losing our hopes on that, and we will probably be more helpful to the patients by application of functional electrical stimulation. There is a really very nicely going interfaces to control the lower limbs and even upper limbs by functional electric stimulation. They will replace the hopes of patients with the stem cells. My comment is this: we will be giving, we must give our most efforts on developing functional electric stimulation. Thank you.
Thank you, Professor. Zilaly, Dr. Professor Sharif, one question from me. In terms of how hard or easy to do DTI and these advanced MRI scans on these patients with spinal cord injury?
I think they're not that hard. The problem is you just need a software. And if you have the software, you can do it. I can tell you, one of my residents is a computer geek, and he was able to do it. Our hospital guys were saying, no, we can't do this. And he was able to do it on his own computer. So if anybody who's computer geek can do it, I'm sure, or any reasonable MRI should be able to do this. The problem is, obviously, at this time, the recommendation is a patient comes in with trauma. Ideally, you should do a CT. And if there's a problem, then you proceed for surgery as soon as possible. So the studies that were done only with MRI and did not do CT did not show any negative impact. In fact, showed a positive impact. Despite that, in many centers, CT is easily available and quickly done, whereas MRI may take time. In our center, it doesn't matter. We can go get both early. So it's not a problem. But in majority centers, CT is much convenient to get. And that's the reason that at least CT can give you what kind of fracture, what exactly is happening. Basic idea, but for prognosis, you do need an MRI. And that has to come early. So if you can get both together, that's wonderful. If you can't, maybe need to be thinking about moving towards MRI.
A question from Dr. Ulhak along the same line. Dr. Ulhak, do you want to ask the question yourself, please? Thanks.
Yes. Assalamu alaikum. I'm Dr. Anwar Ulhak from Saudi Arabia. My question is, what are the indications for doing these advanced MRI sequences like DTI, perfusion images, and functional MRI in spinal cord injury?
I think at the moment, obviously, what we are doing is, as I showed in my, there was a table, and as we said that some of this is investigational. So DTI, functional MRI is investigational at the moment. It can give you prognosis, but it's, so for example, if somebody's doing a study, then obviously they can do that. But at the moment, T2 weighted MRI would very nicely show it. STIR, GRAS images can show you ligamentous issues. For example, you're looking at C1, C2 issues. So I think at the moment, if you've got a good quality T2 weighted MRI, it can give you all the information that you need for prognosis. And if you look at basic score, it's a very, very simple score. There's nothing to it, and we haven't been using it, but I think we should be thinking about using it more and more, because we can predict which patients will walk again and which patients may not have the same chances.
Thank you.
You're welcome.
Thank you very much. Thank you very much, Professor Sharif. I really appreciate that you're taking the time on a busy day. And also, I'd like to, before I thank the speakers from the morning, I just want to say that the second session, the early afternoon session, will start in 2 hours' time. And we have got fantastic talks from Professor Raj Shekhar, Dr. Galgano, Mr. Nick Zerakis, and also Dr. Walensky on spinal metastasis. So that will be in 2 hours' time. And I got some questions about the certificates. What I will do is that at the end of the 4th session, I will send you a link. I'll post a link on the comment section. And those people who are still there then if you can then fill your names and details, then I will endeavor to get the certificate for you, but I can only do it at the end of the meeting. I hope you understand that. So thank you very much to Professor Zilaly, Professor Mehmet Zilaly, Professor Komal Prasad, Professor Mr. Andres Dimitriadis, and Professor Salman Sharif. This has been an absolute fantastic session, and I really enjoyed it and found it very useful. And this is also I think it's a landmark event in terms of holding a one-day conference of this magnitude, and it has really gone sweetly. And look forward to having you, the faculty, later in the sessions as well. If you can, that will be fantastic. And I will see you soon in 2 hours' time. And please note that the videos have been streamed on the YouTube, so hopefully that will stay there. And I have recorded, then I will put them also later on as well. So everything there to review. Thank you very much. See you in 2 hours' time. This will be the same
Thank
room,
you.
so I'll leave it on. Okay, thank you.
Thank you, Narayan. Goodbye.
Thank you.
Thank you. Bye-bye.
Thanks. See you in 2 hours' time. Thanks. Thanks, Dr.